The first case is an example of infant with feeding-related respiratory findings. A 3-month-old infant is brought to the pediatric clinic due to recurrent coughing and choking during feeding. The baby is on SIP feeds and has poor weight gain. On examination, lung auscultation reveals bilateral crackles, but there is no inspiratory stridor. Oxygen saturation is normal at rest. Which is the most likely diagnosis? Laryngomalacia, bronchiolitis, tracheobronchial fistula, laryngeal cleft, vocal cord paralysis. The correct answer is laryngeal cleft. Explanation: a laryngeal cleft is a congenital defect causing an abnormal connection between the larynx and the esophagus, leading to aspiration during feeding. This commonly presents with choking, coughing, recurrent chest infections, and bilateral crackles due to aspiration. So in this patient, the symptoms here are recurrent coughing and choking during feeding. So the symptoms here are feeding-related respiratory symptoms, and on examination there is bilateral crackles. Aspiration during feeding is a characteristic symptom of laryngeal cleft. Due to the abnormal connection between the esophagus and the larynx, so the food passing through the esophagus during feeding will passes to the larynx through the congenital abnormal connection, which is the cleft. So here on examination, there will be bilateral crackles due to aspiration, and symptoms are often feeding related, which is the key diagnostic clue. Why this is not laryngomalacia? Laryngomalacia causes inspiratory stridor. And here in this case, there is no inspiratory stridor. Inspiratory stridor means weak larynx, laryngomalacia, weak laryngeal cartilage. So the key diagnostic feature of laryngomalacia is inspiratory stridor, not crackles. So here on examination, the bilateral crackles is characteristic for the laryngeal cleft, and the bilateral crackles is not seen in laryngomalacia. In laryngomalacia, symptoms worsen when supine, so it is positional symptoms. In laryngomalacia, the symptoms worsen when the baby is supine, okay? And here, the symptoms are related to feeding, during feeding, not during supine position. Bronchiolitis presents with wheeze and viral prodrome. So bronchiolitis, diagnostic symptoms are wheeze and viral prodrome, not feeding specific symptoms. There is no viral prodrome or wheeze are seen here to diagnose bronchiolitis. Tracheoesophageal fistula usually presents immediately after birth. Tracheoesophageal fistula usually presents immediately after birth with severe feeding intolerance. Tracheoesophageal fistula. So here, this is a 3-month-old. A 3-month-old. So laryngeal cleft may be present at 3 months. The start of presentation may appear at 3 months. However, in tracheoesophageal fistula, usually presents immediately after birth with severe feeding intolerance. So the symptoms starts immediately, not after 3 months. Vocal cord paralysis causes hoarse cry and stridor. Vocal cord paralysis, stridor, and hoarse cry, not aspiration crackles. So in this case, there is no hoarse cry. There is no hoarse cry of vocal cord paralysis. The characteristic feature of vocal cord paralysis is hoarse cry. And the stridor. Here, no respiratory stridor is mentioned here. Stridor is a characteristic feature of vocal cord paralysis. So stridor can be seen in vocal cord paralysis and in laryngomalacia. So stridor is seen in weakness of the laryngeal cartilage and the paralysis of the vocal cord. Stridor, okay? So this was the first case. As you can see here, this case is an example of Seward-James-McLeod syndrome, unilateral bronchiolitis obliterans. So Seward-James-McLeod syndrome refers to unilateral bronchiolitis obliterans resulting from prior viral or mycoplasma infection. So bronchiolitis is diagnosed by a prior viral or mycoplasma infection, and unilateral bronchiolitis will lead to Seward-James-McLeod syndrome. On a chest radiograph, it will present with a smaller hyperlucent lung that demonstrates air trapping on expiration. A smaller hyperlucent lung that demonstrates air trapping on expiration. Chest X-ray and CT scan. Chest X-ray performed in the inspiration shows a smaller right lung with shift of mediastinum rightward and a smaller intercostal space. The right lung is more lucent with attenuated pulmonary vascularity. More lucent right lung with attenuated pulmonary vascularity and smaller in size. So the right lung here is smaller in size but more lucent. CT images confirms the radiographic findings but also show some mild bronchiolitis in the right lung. The right lung is smaller and more lucent with less vascularity than the left lung. Okay, with mediastinal shift to the right. This is Seward-James-McLeod syndrome as a result of unilateral bronchiolitis. Okay, on ventilation perfusion scan, the affected lung will show markedly reduced perfusion. The management here, most patients with Seward-James-McLeod syndrome asymptomatic. However, if the bronchiolitis obliterans is severe, patient may have symptoms reflective of their small airway disease. In this case, the patient had frequent exacerbation of dyspnea related to his bronchiolitis. So some patients may be asymptomatic and other patients may be symptomatic related to the small airway, okay, with exacerbation of dyspnea and asthma. Another example of tracheo bronchial fistula. This case is an example of tracheobronchial fistula. This is a chest radiograph of a neonate. The nasogastric tube is coiled in the upper chest. The stomach contains gas and is correctly located under the left hemidiaphragm. So the nasogastric tube is coiled in the upper chest, indicating esophageal atresia. Bowel gas is seen, indicating that there is fistula, esophageal fistula, distally, okay? So there's esophageal atresia, and the distal pouch, or the distal part of the esophagus, is connected to the tracheobronchial system by a fistula. So there is a distal fistula. This is evidenced by the presence of bowel gas. So the stomach contains gas and is correctly located under the left hemidiaphragm. The inability to pass a nasogastric tube esophageal atresia with a distal tracheo esophageal fistula is the most likely diagnosis. So the most likely diagnosis, esophageal atresia with a distal tracheobronchial fistula. I would recommend the urgent referral to the pediatric surgery. Would be indicated for surgical repair as the patient is at risk of aspiration pneumonia. This patient is at risk of aspiration pneumonia due to esophageal atresia. The patient should have an echo and ultrasound to screen for associated anomalies prior to surgery. This patient, this tracheoesophageal or this esophageal atresia with distal tracheoesophageal fistula could be associated with other abnormalities. This should be screened by ultrasound before surgical correction of the tracheoesophageal fistula. What are the types of tracheoesophageal fistula? 4 types of tracheoesophageal fistula: esophageal atresia with distal tracheoesophageal fistula, H-type tracheoesophageal fistula, esophageal atresia with proximal fistula. So esophageal atresia with distal fistula, esophageal atresia with proximal fistula, H-type fistula only. H-type tracheoesophageal fistula, there is only fistula, no atresia. Esophageal atresia with proximal and distal fistula. So there are 2 fistula here, proximal and distal fistula. Esophageal atresia may occur without fistula. Esophageal atresia only. Fistula only. Proximal fistula only. Distal fistula only. Proximal and distal fistula. How would you investigate a tracheoesophageal fistula? In the presence of patent esophagus, tubogram may be performed. Installation of contrast through a nasogastric tube, gradually withdrawing the tube after fluoroscopic guidance. What are the complications of surgical repair? Esophageal leak, strictures, stenosis. Tracheoesophageal fistula can be associated with vectoral anomalies. Vertebral anomaly, anorectal, cardiac, tracheoesophageal, renal, limb. This is an example of vocal cord paralysis. This patient has a history of 55-year-old man. 55-year-old man with persistent hoarseness of voice. As I mentioned, hoarseness of voice, respiratory stridor are characteristic symptoms of and high pitch voice, which is hoarseness, are characteristic findings of vocal cord paralysis. So in this case, axial post-contrast CT images through the cervical soft tissue showing, or an image through the level of the vocal cords demonstrates asymmetry of the vocal cords with a slight widening of the thyroarytenoid groove. Asymmetry of the vocal cords with a slight widening of the thyroarytenoid groove. Thyroarytenoid. Widening of the thyroarytenoid groove. Widening of the thyroarytenoid groove. A slightly higher axial image shows thickening and anteromedialization of the left aryepiglottic fold. Thickening and anteromedialization of the aryepiglottic fold. Higher image showing thickening and anteromedialization of the aryepiglottic fold. And the enlargement of the enlargement of the piriform sinus. There is also enlargement of the piriform sinus. All of these are CT features of vocal cord paralysis. A lower section through the thyroid gland demonstrates an aggressive lesion of the left lobe of the thyroid. Okay. Extension into the tracheoesophageal groove. There is an aggressive lesion. Here, this is the cause of the vocal cord paralysis. Aggressive lesion within the left lobe of the thyroid gland with extension into the tracheoesophageal groove. Aggressive lesion of the left lobe of the thyroid gland with extension posteriorly into the left tracheoesophageal groove. The diagnosis is vocal cord paralysis. Look for a lesion or injury to the vagus nerve. And it is also important to follow the recurrent laryngeal nerve from the subclavian artery on the right and the aortopulmonary window on the left. Also remember that there is a recurrent laryngeal nerve ascended to the larynx in the tracheoesophageal groove. Okay, so in this case, the recurrent laryngeal nerve is injured at the left tracheoesophageal groove. The left recurrent laryngeal nerve. The left recurrent laryngeal nerve is injured in the left tracheoesophageal groove. This is the cause. The injury of the left recurrent laryngeal nerve leads to the vocal cord paralysis.